Good day. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our webinar series entitled The Medical and Public Health Considerations of COVID-19. Today we have two special presentations. The first presentation, which is our plenary presentation, will be on From Surviving to Thriving, Long-Term Care's Journey with COVID-19. This will be followed by a presentation from the front lines and a report from Israel about their vaccination campaign. Today marks this month, of course, marks the 1 month, the 1 year anniversary of COVID. During this time, ACMT, in conjunction with our partner organizations, has been able to produce over 40 webinars, and we've reached 57,000 registrants, many of which are either physicians or nurses or folks in the public health field, and pharmacists, infection preventionists, as well as some members of the general public. We've been honored to have been joined by 56 plenary presenters during this time, representing medical and public health communities, as well as many federal agencies, including the CDC, FDA, FEMA, DHS, DEA, and others. The series has offered numerous frontline update segments to share real-time experience from healthcare professionals, often during times of surges and other crises, in 10 locations in the US and 13 countries from across the globe, including Africa, Europe, Asia, the Middle East, and South America. Over 20 specific topics have been covered over the course of the series so far. Many topics have been revisited over the months as updates have been developed in these key areas, such as personal protective equipment, testing, treatment therapies, vaccines, public health, and preparedness response. And I just want to thank the audience for supporting this program over the last year. Almost on a weekly basis, we've attracted upwards of 500 to 1,000 registrants at a time, and it's been very gratifying to know that there's so much interest, and we've done our best to try to push out timely, scientific grounded information. Next slide, please. I'd like to thank our webinar series partners again for their promotion of the webinar, weekly webinar series. Next slide. All of our webinars have been recorded and they're up on our website at acmt.net/COVID-19 web, and feel free to revisit any of these webinars on demand. Next slide. We've also accumulated a series of FAQs on many of our webinars, and these can be accessed on our website as well. Next slide. There will be a Q&A at the end of the webinar. The Q&As each week are very robust, with great questions from the audience on a diversity of topics. So I encourage folks to put in their questions into the Q&A box or the chat box, and we'll try to get to as many of the questions at the end as possible. We sometimes run a few minutes after the top of the hour, so we can get to as many of these questions. Next slide. Our speakers do not have any conflicts of interest to disclose. Next slide. At this point, I'd like to welcome our my co-moderator, Dr. Charles McKay. Dr. McKay is past president of the American College of Medical Toxicology and one of the principals on this webinar series and our COVID response. And Dr. McKay is going to introduce our guest moderator at this point. Thank you.
Thank you, Paul. So as Paul mentioned, we have a number of partner organizations as these series have gone on, and I'm happy to introduce one of those partners as a co-executive director of the Association of Healthcare Emergency Preparedness Professionals, Christine Sanger. She is going to be moderating the Q&A at the end, and also introducing the main speaker during the question and answer session. And I would like to also just point out her role as the project coordinator for Center of Preparedness Education at the College of Public Health, the University of Nebraska Medical Center. Christine, thank you for joining us today.
Thank you. And I think it's my job to introduce Kristen Harris, which I have had the pleasure of getting to know over the past 6 months. So Kristen Harris is an RN. She is the VP of Operations for NYE Health Services in Fremont, Nebraska. I'm sure many of you don't know where Fremont, Nebraska is, but I can assure you that it is a thriving town in Nebraska, and she has been doing amazing things with the long-term cares. One of the things I love about Kristen is that she is an RN. She was an RN. She has practical thought process as she creates her innovative solutions to these problems within the COVID response. So with that, I would actually, and the last thing I wanted to mention is that Kristen was the first Nebraskan recently to receive the Women of Distinction Award from Ignite Senior Living. And we are all proud of her for all of her hard work that she has been doing over the past year to allow her to earn that award. With that, I will turn that over to Kristen.
Thank you so much. I appreciate it. Good afternoon, everybody. Like she said, I am Kristen Harris. I am the Vice President of Operations for NYE Health Services, which we are a family-owned long-term care organization out of Fremont, Nebraska. I'm very excited to be here. Hearing Dr. Wax talk about the impact that this webinar has had, I'm extremely honored that you have chosen long-term care to gain some experience in that here today. My hope is that you learn some challenges that we had to overcome, how we found that silver lining, and really that we have a lot of passionate people in long-term care that have a lot of grit and a lot of resilience to fight through this pandemic and really have overcome it in extremely positive ways. So our objectives are to review long-term care's pre-pandemic vulnerabilities, review the ethical challenges that COVID-19 presented within the industry, learn what became most essential during COVID-19, and ways that our industry has found the silver lining. Pre-pandemic risk vulnerabilities. I selected 4 of the most impactful ones. This could be a long list, as would be true for most in the healthcare industry. The staffing crisis that we had prior to the pandemic even occurring was extremely significant. There's an article that I'll share a little later, the details on that, but 94% turnover in the nursing department within long-term care in 2017 and 2018. And that didn't improve as the following years went on. Emergency management preparedness. We did not have respiratory protection programs. We did not stock N95 masks. We didn't have testing kits. We did not have disaster supplies anywhere near capable to be prepared for what this pandemic presented within our industry, as I know is true for a lot of organizations and industries. The regulatory mindset of long-term care is something that I think unless you live in long-term care and work in long-term care, it may not be something that is as well known. We are the second most regulated industry in the entire country. Long-term care is second to only nuclear power. We live by our regulations, and regulatory compliance is how you define success. And the DHHS survey process, the subjectivity of that, what that survey process did during COVID-19 was extremely detrimental. And you take a population of individuals that have a very methodical thought process, that work through regulations. They want to know the rules of the game in order to play the game and win the game. And you throw them into a pandemic where they're having to make quick decisions, change every day. And that's really difficult for leaders within long-term care because it's a complete shift and adaptation that has to happen. So the beginning of the pandemic was really challenging because of that for our industry. And then financial viability. I don't think that's a surprise to anybody. there are significant battles with financial viability and long-term care, specifically around funding of Medicaid programs and reimbursement to facilities across the country that really limit the ability to compete with wage scales and really attract healthcare professionals to our industry, which is what creates that staffing crisis. So you kind of feel like there's this hamster wheel that you're fighting in a lot of the time. Bottom line, we just weren't prepared and we were at significant risk. So mitigating that risk, I remember back in February of last year in Nebraska, watching the situation that was happening out in Kirkland, Washington, the outbreak at the facility out there. And I remember specifically reading the article with this quote in it. And it says, while there is some spread in some communities, there is not national spread of COVID-19. CDC and the federal government are working to keep it that way. And I remember thinking, we have time. We have time to prepare. We're going to come together. We're going to work on a methodical plan, just like we do within our industry. And a week later, here we are in Nebraska, Saturday, March 7th. We just passed that anniversary date. We had our first positive COVID-19 case. And that individual had traveled to Europe and returned. And they had attended, after their return back to Nebraska, attended a large YMCA event in a community where 3 of our campuses are located. And I remember getting the call that we were aware of the case. It occurred within our community. There was exposure. We didn't know how much. And we made that tough decision to close our doors that day to visitation. We didn't know if team members had attended the event. We didn't know if family members that were visiting had attended the event. And we didn't know what the exposure risk was to us at that time. I will never forget making phone calls to every family member of our residents and telling them that they weren't going to be able to visit, and talking to every resident one-on-one and calling every team member to explain what was happening and why. And at that time, we didn't have a lot of answers. We didn't know a lot about the virus. We didn't know what this meant for our industry and what the Department of Health would be guiding us to do, because that's who we'd be looking at, is the Department of Health and Human Services. And I remember telling them, we're hoping this is 2 weeks, a 2-week timeline. And it turned into 3 weeks and 4 weeks and 4 months and 8 months and so on. Bottom line, our overall operations changed overnight for those 3 facilities, and that followed the following Monday with the rest of our facilities in Nebraska. Ethical challenges within long-term care and the COVID-19 pandemic. We could talk for 8 hours on the ethical challenges that we faced in long-term care. The resident rights conflict comes to the top of that. Resident rights state that a person living in a long-term care facility maintains the same rights as an individual in the larger community. But the COVID-19 reality was that safety trumps choice. And furthermore, COVID-19 safety trumps all other safety risks. That meant no haircuts for our residents. And I'm telling you, that was one of the most difficult questions to answer over and over, because that's so important to our people. Our residents had to always wear face masks in presence of another person, whether there was a mask mandate or not. No visitation, no physical contact. They were quarantined for weeks in their rooms or their apartments. And I want to pause there, and I want everyone to honestly think about this. If there was an exposure, if there was one positive team member that potentially exposed residents, those residents were quarantined to their room at a minimum of 2 weeks. That would be like being in your bedroom and not coming out. And that would go on for weeks, because that's how long it would take for the exposure and the outbreak to stop. So things like fall risks, weight loss, depression, residents who are hard of hearing, anxiety challenges. Those risks for residents in long-term care took a back seat to the risk of COVID-19. And that's really difficult for leaders and providers, CNAs, environmental services associates that are providing services to those residents and have to answer those questions day in and day out and monitor those things. It became a real ethical challenge for people. And this picture is so perfect to highlight this. This is from an article and a situation in Greeley, Colorado from last October, where residents at a facility out there were protesting the coronavirus restrictions. They formed a protest against the restrictions. And the quotes that were in the article were, "I'd rather die from COVID than loneliness, prisoners in our own home, and give us freedom." And that makes me emotional as a leader that tries to create a home-like environment. That's a really harsh reality of what our residents were facing. Then you go to the ethical challenges surrounding the vaccine, and this could be an entire presentation in and of itself. Obviously, there is a lot of vaccine hesitancy. There was 90 days ago, and there still is. Vaccines were presented to our industry as one of the only ways that there was light at the end of the tunnel for our residents. This was our opportunity to try to move towards and keep that hope alive towards hugs and visitation for our residents. We did this and promoted this, and there was an unspoken pressure to do this successfully. We had no awareness of what the restriction changes would be. Most of our residents and team members were vaccinated back in January. And when we had questions from family members of what does this mean? Do I get to come in and hug mom? Or a resident saying, do I get to go out and see my family now? We didn't have answers. It wasn't a no, it's an I don't know. And that is really difficult to speak to over and over, and trying to navigate that communication with family and encourage this, but not be able to give specifics on what it means. It becomes really complicated. Our plan as an organization, and most of the long-term care organization, was to provide sincere, genuine information sharing. We had some partners that helped us with that. Like Christine said, our ECHO partnership worked as a collaborative long-term care group that developed a letter to go out to family members. And our goal was to be transparent and honest and allow people to make the best informed decision possible. The frequently asked questions we received, some of them were, will they be mandated? Are you going to make us take the vaccine like you made us do COVID-19 testing? Do we get paid time off if we have a reaction? Is that the responsibility of the employer? And how are you choosing who gets it first? When the vaccine was first coming out, we had no idea how many we were going to be getting. We didn't know if we were going to get to do our entire population, or if we were going to have to divide it in half, in thirds, and how do we choose who gets it first? I'm very proud to say that our organization achieved 95% of its residents to get vaccinated, and 70% of its team members. And in all honesty, I was shooting for 75, but 70 is so exceptional when really the average across the country is between 40 and 50%. We utilized this as an opportunity to celebrate. We made this the light at the end of the tunnel, and there were tears, lots and lots of happy tears, both team members and residents, because it was a sign of hope and, a sign of us being able to move forward towards those hugs. Then you also have the stigma battle, and this is not news to anybody. There is a historical perception within long-term care that is very public with some of the challenges that long-term care has faced over the years. This is the article I was referring to, alarming nurse turnover rates. One way that I felt that I could share with you how critical this was to our industry is in relation to the National Quality Awards that came out last year. Every year, the American Healthcare Association promotes National Quality Awards. And our organization, I'm very proud that Nebraska had 7 silver quality awards, and Nye Health Services earned 3 of those 7. 3 facilities received silver awards. We were discouraged from promoting that. We were discouraged from putting it on social media, a time when our residents needed some uplifting, happy news. And when our team members needed some good news, we couldn't share what we had earned because of what the media and the social media, the news outlets, because of the way things had been portrayed. The risk was enough that it would be turned into a negative. And so across the country, buildings that received these awards didn't get them. We already talked a little bit about the CMS 5-star rating and the subjectivity of the survey process. And then last is this Facebook post that was our world over and over every day, as it was a lot of healthcare. But it talks about how a facility in Nebraska is in desperate needs of CNAs, med aides, and nurses. They have over 230 residents, had their first outbreak with multiple cases, and staff walked out. They left. They did not stay. And the staff that were there could not get anybody to come and help. There weren't enough people. So of course that COVID-19 exposure risk expanded. Very, very deflating. So as an industry, how do you win a losing battle? And this is the picture that I put up all the time for our teams, is you go to the mattresses, you fight, and you find that silver lining. And this is Meg Ryan and You've Got Mail, punching to the air, fighting for her business and what she believes in. And that's what we had to do. You focus on what is essential, and that is culture. Team member retention was the name of the game throughout the pandemic, because team members they were our greatest asset. They always are, and it became that much more critical. You had to focus on culture and the power of influence. You had to create a work family so that there was a dedication between peers that they didn't want to leave each other. You had to intentionally create moments for those things to happen. Finding the joy and purpose, sharing the good news. It's difficult to look at a CNA whose purpose in being a CNA is to have connection with a resident and then tell them until further notice, you don't go in that resident room and you limit your time to the cares only. And that's what was presented at the beginning of the pandemic and through most of the pandemic, was minimal contact as much as possible. Calling all superheroes, using that call to action, and trying to get people attracted to our industry as opposed to leaving our industry. Wage scale increases. Yes, even during a pandemic, there wasn't a choice but to compete in ways that we had not before for team members, and implementing things such as a team member crisis fund. Resident experience, celebrating life in our environments. We were really challenged with an environment that did not allow entertainment to come in anymore, didn't allow group gatherings and socialization. We didn't allow family to come in and have connections with residents personally in our buildings. Our challenge as an industry was to take the everyday and ordinary moments that we always have and make those special. And that's what we really challenged ourselves to do, is find those everyday moments and make them special for our residents, and definitely prioritizing resident and family connections. And here are some of our wonderful residents smiling behind their masks. They are smiling with their eyeballs. And yes, we're in Nebraska, so anytime Herbie Husker shows up, residents are pretty happy about that. Infection prevention. We implemented dedicated COVID units in our long-term care facilities, and we took COVID-19 admissions. We requested them. We decided we were going to play offense, not defense. And we prepared our people, we trained our people, and we fought to be the best at it. Guideline changes at lightning speed. Respiratory protection programs. We have them now, everybody. Company-wide management and distribution of PPE. This picture up here is a good example of what our campuses and our team members were faced with every day, and not just in long-term care. This box contains materials that are past the manufacturer's expiration date. We cannot verify the effectiveness of these supplies, and liability for their use is assumed by the user. So we would get calls at our home office saying, can we use these? The health department dropped them off. Is that okay? Those are challenges that there were no good answers to in the moment, because you didn't know if that's all you were getting. And then communication, sharing the positive news, keeping it personal. One of our challenges our organization felt very much at the beginning is we're a very personal company. We are a very home-like company. We build our mission, vision, values on relationships. And that's the way a lot of long-term care is. It's personal. And so those face-to-face conversations couldn't happen anymore. How do you adapt your business and your operations to still make it feel personal with team members, with residents, and with family members? So there were daily company-wide all leadership team meetings. Resident, family, and team member communication was aggressively enhanced and prioritized. Personal phone calls to family members and residents and team members, weekly updates to both family members and team members. There was so much fear of the unknown. And I always say that if you don't provide people enough information in between, they're going to fill in their own gaps. So our goal was to be transparent. And if we didn't know an answer, we said we don't know. But when we do, we will be communicating it immediately. And that action, those communications create a trust and a relationship that helped us unite and kind of lock arms with each other, residents, families, and team members, and push through the pandemic to where we are now. So my favorite page is the silver lining of COVID-19, because in all honesty, COVID-19 has impacted our industry in ways that would not have happened otherwise. COVID relationships, that's what I'm calling them. There has been such an enhanced focus on relationships because it was necessary. Team member retention is significantly improved. Our organization had an overall 77% turnover, which is lower than the 94%. So we're proud of that, but nowhere near where we would want it. We are currently at a 38% annualized average, and we believe that's because of the things we modified during COVID. Family and resident communication and the trust that was created there, and strategic partnerships. COVID-19 forced our industry and organizations within our industry to look beyond our walls, to adapt and align on a bigger scale and in a bigger picture, and grow those strategic partnerships that will help us grow as an industry. Medicaid reimbursement improvements. Very, very thankful for the support and modifications that were made during COVID-19, because there were some at the state level that occurred. We are optimistic that there is better awareness to truly how detrimental being underfunded in that way is to the residents and to our ability to compete for team members, and that will be something that we anticipate growth and sustainment moving forward. The Department of Health and Human Services and Providers Survey Management Work Group. I have been one of 4 providers in the state of Nebraska that is participating on a work group with the Department of Health and Human Services. And I'm very thankful that our regulatory surveyors identified that COVID-19 kind of shone a light on the challenges that we have within our survey process and the disconnect that we have, when really we're all fighting for the same thing. And it feels a lot of times like we're butting heads more than we're fighting for truly resident health and satisfaction. And so we are focusing on culture. We are focusing on prioritizing communication between DHHS and providers, and are very excited about what that means for long-term care in Nebraska. And then enhanced operations. There are many. I could probably have 50 things bulleted here, but I chose communication platforms and technology, virtual prospect tours, telehealth services, EverSound, which is the headphone system that Virgil, our wonderful resident in the corner up there, along with Connor, one of our team members, is wearing. LifeLoop, which is a platform that connects residents with their families, and AccuShield, which is a visitor management screening and team member screening system. Lots of improvements in communication and technology that would not have happened. I truly believe that if it weren't for COVID-19. So I hope that after everything I've shared with you, yes, I've shared the challenges, but I really hope that I have highlighted that there was good news throughout COVID-19, and that we have some very strong, resilient individuals in our industry fighting for our people, our team members, and our residents. And I want to thank all of you for supporting our industry today and being on the call. Thank you.
Thank you, Chris, and thank you for your presentation of the challenges, philosophical, logistical, and otherwise, over this long year here in the U.S. Please, those who have questions, encourage you to write those in. We're going to hear now from Dr. Ophir Lavon, who presented to us back in July on the experience in Israel with the infections coming through the country of Israel. And as we've invited him back now to present the perspective on the vaccination program and its successes and the challenges with that, but mostly the successes, and a little bit of a comment in the next few minutes on some of the things he's been seeing with the vaccinations and the side effects that they've been occurring, and putting those into perspective. Ophir, thanks very much. Go right ahead.
Thank you. It's a pleasure to speak again, and especially that we are looking at the future and seeing some brighter future. I will focus on the vaccination campaign in Israel, which is really has some great results that can be copied elsewhere in the world. First of all, let's see. All right, so this is Israel. If we look back, it's right there in the Middle East, between Europe, Asia, and Africa. You can see a closer look of Israel and its neighboring countries. And we are a small country, and this is, in this case, an advantage when, regarding the vaccination. We are about 9 million people and about the size of New Jersey. So it's not a big country at all. And another key point is the fact that our health system is mainly a public-based one. We have a private health system, but in Israel for at least 30 years, all the Israeli citizens are covered with a national health insurance that provides a very nice, very expanded health services package. And this service is given by 4 organizations, HMOs, and the largest one covers about half of the Israeli citizens, and I'm one of its employees in one of their hospitals. And all of the Israeli public health system is actually fully digital, fully with digital health records. And this is another key point for the discussion of the vaccination that helped to get the results that you will shortly see. And we have over 30 general hospitals, and most of them are actually at a university affiliated level. So we are talking about a high-end quality medicine in Israel. Now, this is taken 4 days ago from the WHO dashboard website regarding COVID. And you can see that actually the numbers in Israel, if you take about the 800,000 or something people that were confirmed cases of COVID, and you divide it by the population, our morbidity is not that low. When I talked 10 months ago in May, we were in a very good place. If I will move my cursor, we were about here. And of course, looking at the next waves of morbidity, March 2020 was like a little bump. So in regard of a contagious or infection, Israel is right in the middle, not leading like, for example, New Zealand. If you look at the mortality rate, it's pretty low. It's about 6,000. Today, we touched the 6,000 COVID-related deaths throughout the last year. It's less than 1% of the confirmed cases, which is a good figure compared to other countries. And it is related first for the relatively younger population in Israel, and also to our quality of medicine and medical services that are given. If you move forward, this is a busy but a very important slide. I will go step by step. First of all, we are looking at this timeline. We see the last 6 months, and around the late summer or early autumn in September, we had our let's say second big wave of morbidity, and we went into our second lockdown. And you can see the numbers of a few thousand of new cases per day, confirmed cases. And then we had a decrease in the numbers. And soon at the end of the year, we got into our highest morbidity wave that started in late December. But something had happened since then. You can see the green squares showing the timeline of the vaccination. Now, you remember that the FDA approved the Pfizer vaccination, which is the one that is given in Israel in about mid-December. And about a week later, also Israel Ministry of Health issued an emergency approval for the Pfizer vaccination. And vaccination it started in the last week of December. I myself got my first vaccine shot in December 26th. Now, the number of vaccination ampoules or the vaccines themselves that were available became more and more available because Pfizer and the Israel Ministry of Health, it came to an agreement that beyond the commercial aspect of this agreement, paying and getting the product like any other customer, Israel is a great place for Pfizer to really see the influence of their vaccine and compare the clinical trial to real-world post-marketing data, because Israel is a relatively small country, easy to move around and move this vaccine that needs storage in deep freeze temperature. We have our very, very efficient HMOs with digital infrastructure, and part of the success is the fact that we were provided with the vaccines, and the numbers are not that big. I mean, relatively, I mean, a few millions is not that big a number compared, for example, to the US. And you can see the numbers that it's less than 3 months by now. And if we move forward, you can see that the numbers are going down. For example, the last month, the numbers of fatalities per day are going down. And the reason is, and you can see it in this slide, this is again updated to 4 days ago. And today I can tell you it's 5.2 million people in Israel that got their first vaccine shot, and 4.2 million that got both of the vaccine shots, and close to 4 million that are fully vaccinated, as more than a week has passed since their last vaccine shot. And these numbers, if you look at it, are not just high, but also very efficient, because you can see highlighted in blue the vaccinated percentage of the main risk group, which are the elderly. Over 50 years old and all the way up to 80s and more, we got 80, 85, and 90% of the people in Israel, the elderly, are vaccinated. And if you look at the left, you see that all the 16 years old and older, the people that can get the vaccine, we're talking now, it's 56, actually it's today close to 60% all over Israel. And again, if you look here, it's all together, we're getting 80%, very high numbers regarding vaccination. And if you look at the numbers of the adults in Israel, we are left in about 1 million people to vaccinate, and about 250,000 to vaccinate people that are 50 years and older. Of course, there are people that are that have hesitation regarding vaccination, but relatively, if you compare our country to other countries, for example, to European countries, we have a higher percentage of citizens that were willing and are willing to get vaccinated. And I will add that you can see this success regarding another risk group, which are pregnant women. When the vaccine was presented and approved, there were concerns regarding pregnancy. But we know today that COVID is a dangerous thing for pregnant women, especially at the last trimester. And in Israel, we had a campaign that convinced pregnant women to get vaccinated, at least from the second trimester. And we get a very high return rate of pregnant women that are vaccinated, and the results are showing up. We know today that pregnant women who got vaccinated are less infected and have a much better results regarding COVID. Some more data, you can see some pictures of the vaccination campaign. All the HMOs and organized with compounds in clinics and in other places, also using the drive-in vaccination compounds. And you see younger people and older people. We heard about the long-term care facilities, and of course, they were all vaccinated very, very systematically. And if we look further, the main results of efficacy were presented in a very recent recent paper in the New England Journal of Medicine, data that came from the main HMO in Israel. And this is the main results in the figures that you see. And throughout all the different parameters of confirmed infection, symptomatic infection, severe infection, hospitalization, and so on, you see the great benefit of the people that were vaccinated. And regarding, and some more data, today we know that if you look at people that are now hospitalized with COVID, more than 90% of people that are not vaccinated are not fully vaccinated. And again, with the pregnant women, the same great results. Regarding safety, it's truly this vaccine. I'm talking about the Pfizer, the mRNA based vaccine. It has a very good, positive safety profile, and it truly correlates with the data coming from the clinical trials, mainly mild and transient reactions. There were some new signal that it's still mild and transient, but something that wasn't presented in the clinical trial. There are some people immediately after vaccination or close to the vaccination that complain of some paresthesia in different parts of the body, something that is still investigated, but it doesn't look a serious signal. There were no related fatalities, and anaphylaxis rate is actually the same as documented in the US, 3-4 cases per million, which of course a very rare incidence. And we are still looking at some issues, for example, post-vaccine immune diseases, a thing that is now under surveillance. Lastly, some concerns. The headline should be concerns and not safety. Children, of course, if we want to vaccinate almost all the population, and especially in Israel that we have a lot of children relatively, we need to go down and start vaccinating children. We are waiting for the data coming from Pfizer extended trial regarding children, especially 10, 12 years old and older. We are concerned about the duration of the vaccine, when we are going to need to get some booster shots. And of course, main concern globally is the viral variants. And what about the efficacy of the different vaccines? And can we use other vaccines? For example, myself got the Pfizer vaccine. What about in a year? What about a booster using another kind of vaccine? It's a question. And of course, the long-term adverse reaction, probably not a great concern, but still something to look and have some surveillance regarding that. And with that, I conclude, and then we're happy to hear your question. Thank you.
Great. So thank you both for such excellent presentations. Really fascinating work that you've been able to deliver us on two different topics, but of course they're connected together as we all know. So I encourage folks to put in their questions into the Q&A box or the chat box on either presentation. We have a few minutes left, and we would like to respond to folks' queries. So at this point, I'm going to ask Christine to address a couple of the questions to Kristen, and we'll move from there.
Okay, thank you. Kristen, there was a question about what we've learned to create resiliency in healthcare for future disasters. And thinking about that, much of emergency planning is related to the long-term care focused on forward movement of patients and evacuation, but not really epidemics or outbreaks. Were the Medical Reserve Corps or state or local regional emergency planning committees used to help your response in the long-term cares? Or were their capabilities not as relevant to the long-term cares and they just weren't all that helpful?
Yeah, not in our state. I will say we did not have a lot of support or service from them. If it was related to supply deliveries. They kind of did jump in and help facilitate deliveries from the health department for outbreak status support and or COVID-19 testing. That early on in the pandemic, when there were not COVID-19 tests available and a facility was in an outbreak, we didn't have access to any testing. And the only way we could get it is through the health department. And it was such a controlled process because there were so few of them that they did utilize those services to complete COVID-19 testing within campuses.
Do you expect plans to be augmented to include you guys a little bit more with some of that planning in the future? I mean, is this a lesson learned, or is this just something that really doesn't fit?
I hope so. I think, unfortunately, there was a lot of conflict around the challenges that you had hospitals that were short-staffed. You had challenges all across our country, and how do you decide where those services go? And I know those were difficult decisions that were being made every day. I'm very hopeful that there is more of a priority because there were very negative outcomes with what happened, unfortunately, early on when that Facebook post that I put out there, that's a perfect example of no support available. There were not people to respond to those needs of those residents, and the staff that were there were the same ones there every day because so many had left. And so I am very hopeful that it is. We're definitely advocating for that, but we won't know that until things move forward.
I wanted to ask a follow-up question to Kristen about folks in the long-term care facilities that may defer on the vaccine, who may not want the vaccine for a variety of reasons. Yeah, if you could just address again, how in general do many of these long-term care facilities handle those sorts of patients, and what sort of secondary issues result from the vaccine hesitancy within the long-term care facility?
Yeah, thankfully, I would say it's a small population, so that is good. But the CMS guidance that came out last week related to long-term care and visitation is very centered around the ability to move forward with visitation and physical contact. And there are a lot of stipulations around whether people are vaccinated or not. Do residents that go out into the community, depending on the county positivity rate, coming back to the facility have to be quarantined for 2 weeks? Because that's what we've been doing for a year. Anytime they go out and they come back, they're in quarantine due to potential exposure risk. Based on county positivity rates, residents that are vaccinated may not need to be quarantined. Residents that are not vaccinated will need to be quarantined. So those are things that we're now having to be a lot more aggressive educating on, and hopefully we can continue to get towards that 100% preference of accepting that vaccine. But there are definite modifications that will be made in regards to restrictions for residents that have the vaccine and residents that do not.
Okay, great. Actually, a very interesting question just came in about chronic health conditions such as dementia or Parkinson's or depression, and whether some of these conditions progressed more rapidly during the lockdown and the isolation of the long-term care facility residents. Do you have much info on that?
Well, I would tell you that all of my nurses would say yes, that it was very detrimental. And in long-term care, we did all we could to try and mitigate those risks and those challenges. But the reality is the level of engagement and communication and conversation and things that keep people engaged decreased significantly until those communication platforms that I talked about were implemented, and that took time to do. And there's a lot of information starting to come out about things like COVID brain and the people that have even had COVID, what's that doing to residents with dementia that had COVID, and how quickly that's progressing their symptoms, things like that. Definitely our nurses would say yes.
Okay, and one additional question to Kristen at this point. Do you do, or are you still doing regular COVID testing of the staff, even though they've already been vaccinated?
Yes, absolutely. We're following the guidance based on the county positivity rate, and we still have counties over 10%. We have a couple that are under 5%, which is exciting. That's once a month testing. But we have most of our campuses are doing at least once a week testing on team members, and it's mandatory testing.
Even if they've already been vaccinated?
Yes. Yep. There is no change in long-term care. There was no change to our guidance and expectation related to COVID-19 testing based on the vaccination status of people.
Okay, great. Thank you.
Yep.
Chuck, did you want to ask some questions of Orfea? A number of them have come into the box.
Sure. I see one other question though, Christine, referring back to the issue of the interaction between long-term care facilities and acute care facilities, or some of the problems which varied quite a bit by state about how to address both the discharge of patients, but also the communication with admissions or referral for emergency assessments. Do you want to address that, at least from your experience there in Nebraska?
Do you want me to take that, Christine?
Yeah.
Yeah, I would say, in all honesty, we had good relationships with our hospital systems in Nebraska. We already had those relationships set up. That was something that we is a priority to us because of that transition to care plan for our residents and the trauma that can occur with that. So we have a very intentional process with admissions. So we were able to take that and just adapt it. The communication from the hospitals was actually really positive. It was collaborative. There was an effort we tried to be a partner with the hospitals because they were making as difficult of decisions as we were every day on what needed to happen if we were able to support the needs of those residents or not. And, early in the pandemic, it was no admissions to the nursing home, 0, no COVID-19 going to long-term care. And boy, did that change over time, because in necessity, there was no choice but to admit to the nursing home and the long-term care facility. And so it was very supportive and positive. I would say that based on the capacity of the hospital, you definitely could feel the urgency changing in the people that we were working with, and we did our best to try and support that how we could, but we still stayed very true to whether we really could provide care to the patient or not, and they respected that most of the time.
And I have an additional comment to that answer. In doing, I don't know how many of you remember, but in pandemic preparedness planning that has been happening historically over all of the years here in this country, one of the plans was we were going to overflow our hospitals to long-term cares. It was not really this opposite, this pandemic, this fictional pandemic that we were all planning for, wasn't really on the opposite end. We were going to let the long-term cares take the excess and not the other way around. And so, I think that we had always made plans and had lots of communication, at least here in this state, with our partners in long-term care and the hospitals that were connected to them. But it is the thing about COVID is you had to be ready to shift your plans and be innovative at all times and be ready to create new plans, even though we had some plans before. So it's a perfect example of how just knowing the right people is a big part of being ready for anything.
I think I'd probably emphasize that whole idea of communication can certainly be one thing that'll come through when all the plans have to be rewritten on the fly. If you haven't had that communication, there's no hope of getting there. But the variation from state to state here in terms of cohorting patients or discharge to nursing homes or never going to a nursing home and designating certain nursing homes as a COVID facility. Yeah, if you're facing that with inadequate staff and mixed messaging about the quality or absence of your PPE, yeah, that does not sound like a good way to start. If no other comments right on that, let's go to Ophir. Certainly, you guys are having a very great success in getting the vaccine out. Somebody has asked whether that has incorporated pharmacists or community pharmacies in addition to the vaccination clinics that you had depicted in your presentation.
Well, pharmacies are not places that are approved for vaccination, but they are not needed. Clinics are located all over the country. Pharmacists are part of the teams that help nurses and other professionals to provide the vaccines. So we have the infrastructure to give the vaccines in all places. Regarding the long-term care facilities, this was a struggle at first because the Pfizer vaccine needs to be stored until now, at least. They a bit changed it, but the instruction were to store it all the way down to -70, -80 degrees centigrade. And because each of the vial is 5 or 6 doses, you should use it very carefully. So you need to bring the patients to those clinics, and the thought of taking the vaccines to the long-term care facilities was a bit of a trouble, but they succeeded, again, because the country is relatively small and there are a lot of clinics. So eventually, as you saw the numbers, over 90% of the elderly are already vaccinated.
Yeah, I have a follow-up question about, on one of your slides, you mentioned having the number of vaccine, the percent vaccinated versus those with the I forget what you call it, the vaccine card or
they call it Green Pass. It's
Green Pass. What's the difference? But the numbers were not the same. What's the difference between the Green Pass and those vaccinated?
Yeah, first of all, the vaccinated that you saw, it's at least one vaccine shot. So it's the whole package. You know that in the UK they decided as a policy to give just one vaccine shot at this time to provide a vaccine to more of the population. In Israel, we want to complete the whole protocol. So the green numbers that you saw in the slides, and they are available to you to see again, are the ones that we know that are fully vaccinated. We know from the numbers and the data that about 2 weeks after the first vaccination, it's for good more than 50%, but close to 80% protection if you compare it to placebo. And after a week or two after the second vaccine that is provided, the 3 weeks from the first vaccine, you get the 95 and up, and probably even more. And then this is the people that are given Green Pass, which means that nowadays, just to give some data, in Israel, many restrictions are lifted off. For example, people are getting back to all kind of activities, but some of the activities are open just to people that present the Green Pass. And if they are children, they need to bring a PCR, a negative PCR result. But so this definition of Green Pass has some influence of the day-to-day. It's called Green Pass and Purple. Purple is just one that is not sick and he doesn't have any fever. And the Green Pass is already vaccinated, fully vaccinated.
Well, Fear, you had mentioned a lot of data in those slides, and I think it is a pretty rich, resource for looking for information to apply more generally. Several people have asked some questions that you might be able to answer off that. One is related to any information available about the infectivity of those who are vaccinated, and also the long-term follow-up of any long-term symptoms, which I imagine you might be able to have access to with that pretty extensive electronic record.
Yeah, of course. So regarding infectivity, which was something that is still, but was more of a concern because it wasn't investigated in the Pfizer trial because it's a difficult thing to track. But now we have data because of surveillance of people that were vaccinated and are repeatedly checked that the vaccine also provide a relatively high percentage of reduction of the infectivity. Some say even 80%. Now the number are still getting in because we want to wait, because you don't know if the chance that the person was confronted with the patient that is confirmed and see if the vaccination status has helped him to be less infected. So it's more like an epidemiological data that will be gathered throughout the weeks. Again, we are less than 3 months since we started the campaign, but it seems that it's going down. Why? 3 weeks ago, we had our Jewish holiday. It's called Purim. It's a kind of a holiday which is a very with a lot of festivals and parties, and people are putting on costumes. Last year, this was the first of the wave, people coming around and getting infected. This year, the government were very concerned. There were a lot of restrictions, but people went out, and there were a lot of people that didn't listen to the restriction and all the guidance. And yet, we didn't have any increase in morbidity in infection, which means that the vaccine has its effect. There isn't any other explanation why people went out to street parties and a contagious factor went down. This answers a practical question, not from a scientific point of view, from a practical point of view. This in infectivity, long-term effect, we know as physicians that most of the adverse reactions of vaccines are short-term, at least in the first few weeks. And we understand the new technology of mRNA. So actually the potential of serious long-term effects is actually very low, but we look at it, especially as I told you, the neurological aspects that were not so investigated in the trials, and also the autoimmune effects, which seems low, but are concerned that this is something that is looked for as part of the surveillance campaign. They put up some points to look for to all physicians to be more aware, and the immune reactions are one of our main goals of surveillance. Still, it looks very safe.
I think you answered then one of the questions that just came in terms of certain groups that I know we've seen in the news tend to either congregate and or refuse vaccination. I would imagine they are just carrying purple cards for any activities. Would that be accurate interpretation? Or
well, it's the purple is not a purple card. It's if you want to work, for example, for stores and supermarkets, you cannot deny people that are not vaccinated. But you can say, okay, if you are confirmed, you should, of course, go to quarantine, or if you have some symptoms. So this is regarded like the purple, I don't know, purple status or something. It's not personal. It's the way you handle things. So, for example, supermarkets, of course, people can come in unless they are confirmed. There are some activities, for example, social activities like going now to for example, for concerts, they are now starting to put again a sports event. For those events, only if you are vaccinated or were infected and recovered, and people are getting. I can even try to find. I have a barcode in my cell phone, and I can show it, and they use it, and then you can enter. Of course, people can say you can fake it, but this is the way it's done. And again, this is something that probably will be done when all the universe will come together, for example, into airports and going from country to country, some system of clearance of people that are vaccinated or recovered should be put forward. So in Israel, we have this system, and this is how we go around.
Well, the lack of outbreaks after Purim would suggest anyways that you may be approaching herd immunity, which we all are hoping for through this process.
Yeah, I don't know about.
Go ahead.
Herd immunity is I know it's debated. What is the percentage? And especially, again, one of the concerns is if we get a new viral variant. In Israel today, the famous British variant, I don't know the number, B somewhere 150, I can't recall it right now. It got also to Israel, and most of the confirmed cases are the British variant. We don't know about the other variants, which are not yet spread in Israel, and about the efficacy of the vaccine. So actually, we know that we do want to thrive to a higher percentage, and in this way we will be more, let's say, protected from more infectious variants if they get, because still people are coming to Israel. I mean, the borders are not shut down totally. There are still people that come in, and they can bring new variants.
Well, speaking of the borders and with the information you have, do you have information to address concerns and questions that have been raised about vaccine administration to the Palestinian populations?
Yeah, so first of all, in Israel, we have a few tens of thousands, about 30,000 or so, Palestinian workers that are working regularly in Israel in different working fields. They have permits to come in, and they are vaccinated by the Israeli government, not just Palestinian workers, also, if we talked about today about the long-term care facilities, another option for elderly people that need help is getting a worker at their home. And many of them are not Israelis. They come from different countries. They are foreigners. They are also vaccinated. When the elderly came to be vaccinated, their workers, their foreign workers were vaccinated themselves. So in Israel, people that come in, even if they are not citizens, everybody gets the vaccination. It's an ongoing campaign. In the Palestinian Authority, some vaccination have been given, not a lot, some, but also all the permits to bring in vaccination from other countries for the Palestinians are given. There are no restriction from the Israeli government regarding the provision of vaccination from any source.
Paul, I see there's another question that I think Kristen is directed at you. I'm going to read it to you, although I have a feeling it's going to take me less time to read it than it will to give the answers. Guidance about how facilities would handle a positive COVID-19 outbreak in their take long-term care facility, where a resident maybe had one or of the two vaccinations and tested positive. And if the residents are completely vaccinated, are they, as the staff, going to implement PPE in dealing with that resident or within that facility? So how are you handling that now compared to early on in the epidemic when nobody had, vaccination or native disease to protect them? At this point, how are you handling that kind of a introduction into a facility?
Yep. So unfortunately, nothing has changed in our industry. The guidance we've received from CMS and from the Department of Health and Human Services that was the same pre-vaccination is still the same post-vaccination. I'm hopeful that that's something that will change over time. But if there is a positive case, even if there's a vaccinated resident at this point, there is still an expectation to quarantine based on the exposure risk and implement outbreak testing, which means if there is one positive team member or one positive resident, your entire facility, your entire environment is tested for 2 weeks. 2 weeks straight. If we, after the first round of testing, if you identify that it's isolated just to a certain area of your environment, a certain hallway, a certain floor, then they will allow for the other neighborhoods to continue to be in what we call a green zone in our industry. They can still attend communal dining and communal activities and things like that. But the testing will continue for 2 weeks, and the quarantine for those residents based on exposure will continue. There has been no change in the guidance related to that, unfortunately. Those are the hard conversations to have with families and residents. Here we are 2 months after they've been vaccinated, and those aren't things that have changed yet for those residents.
And especially with the new statements about, visiting starting back up again, that's going to become a complicated message.
Yep.
Kristen, there's a couple of other questions that I think are going to be easy for you to answer real quick. One of them was about PPE and vaccinated, for your vaccinated staff. Are they still required to wear PPE? And then the other one was about hospital admissions and residents that are being admitted straight from the hospital. Do you require the hospital, the acute care hospital, to give them their vaccine before you get those patients? Or is there a system worked out for you guys?
Yeah. All team members, regardless of vaccination status, have to still comply with all of the PPE requirements based on the outbreak status of the facility. So if there's no positive cases, they're still wearing surgical masks every day for every shift, and normal infection prevention precautions are in place. If there is a positive case, then you go into full PPE. As far as, so that is something, again, hopefully over time, all of our team members, I know everybody everywhere is so excited the day you can take masks off and look at each other with real smiles, not just smiling with your eyeballs. But that is not where we're at this point. In regards to admissions, we do not require for the hospitals, the acute care facilities, to complete the vaccines. We would appreciate if the hospitals would complete the vaccines prior to residents coming into our environment. And that is something that our organization in Nebraska is pushing for with the hospital systems, and trying to get that prioritized and make sure that the hospitals have the vaccine to provide to those patients before they come to us. But they do not have a system set up yet for that, and the hospitals do not have access to everything they would need in order to complete that for every admission to a skilled nursing facility right now. But I would love it if that happened, Christine. That'd be great.
We'll have to work on that.
I think we'll close it up after another one or two questions or fear. A couple interesting questions. One is about the development of immunity in patients that have in vaccinated autoimmune disease patients. So people with pre-existing autoimmune disease who have become vaccinated, how do they do with the development of the immunity? Do you have any data on that or information? You're on mute.
Yeah, okay, great. First of all, the policy is, of course, to vaccinate. There aren't any limitation vaccinated people with different immune disorders or people that are treated with immune or kind of immune suppressant. We know that there is a potential that they will not be fully protected. I'm not aware of serious data or official data that have checked. We know that there are some issues in trying to evaluate their status, or any status of people after vaccination using a serology, because it's not yet something that you can say it correlates to the clinical parameter. But it seems that most of them do handle, do get enough protection, as I said, because we see that among people hospitalized, and again, we focus on the severe morbidity, we focus on hospitalization, of course, mortality. We see that the numbers or the percentage of people that were vaccinated, and again, 1 or 2 weeks have passed since the second vaccination, we almost don't see them, and probably it's something that is relevant to all population, including those people that are not a minority. And with that, we see that the only true, because there were some debate about it, the only true contraindication is people that developed true anaphylaxis after the first shot, which means that there isn't even any contraindication for the first mRNA vaccination, but for the second, only people with true anaphylaxis have a true contraindication, and they are rare. So we are not really concerned about holding back the vaccination. As I told you, we recommend to pregnant women, to women that are breastfeeding. There are data coming out, good data showing that pregnant women are not only protected, but their fetus is protected because the antibodies are going through and getting to the fetuses. So it's even better. And also there are some data, not just from Israel, that are published that also babies that are fed, breastfed, are getting some antibodies from their vaccinated mothers. So, so again, a very positive results, which means everybody are more than welcome to get vaccinated because the benefit outweighs any risk.
Great. Well, on that note, I'd like to wrap it up and thank both of our speakers again for excellent presentations. And it was very informative and great Q&A session as well. I'd like to thank our guest moderator, Christine Sanger, and Dr. McKay for their moderation today, which was really excellent. Could we go to the next slide, please? So our next webinar is in 2 weeks. We're going to take the week off next week, but in 2 weeks' time, we're going to have a webinar on ethical challenges during the COVID-19. And we have two ethicists who will be joining us for what should be really a fascinating discussion. Next slide. Our webinar series is summarized in our prospectus, which is also available on our website, and you can look back and on any of our webinars and feel free to access them on demand. Certainly, we've learned a tremendous amount over the course of the last year as the knowledge has continued to evolve and change. I'd like to thank everyone for attending today, and